Today we're going to talk about neuro exam. Neuro exam has four basic components. The first one is mental status assessment, which we are not going to demonstrate in this video. Then you have cranial nerves, and then sensory exam, and then finally motor exam. The motor exam includes strength, and then also coordination and cerebellar function. So let's do cranial nerves. The first cranial nerve, numero uno, is olfactory. So we have the patient sniff something. We are going to skip that demonstration. But I will mention the two most common smells in the hospital, well, besides feces, which we're not going to have the patient assess, would be alcohol, like alcohol prep pads, and coffee, both of which are irritating to the nose and should not be used to test olfactory sensation. Sorry. Second is number two, the optic nerve. So for this, we are going to ask the patient to read a little card. Read the smallest line you can read.
374258.
Okay. Next, we can also do what is known as the confrontation test, or visual fields. So what we're going to do is we're going to stand directly in front of the patient, and we're going to use our fingers like this. So I want you to cover up one eye, and I want you to tell me how many fingers you see.
Two.
Now look at me.
Oh.
How many do you see?
Two.
Okay. So what that says is she was not able to see all four fingers in this area.
I have to add them?
Yes.
Oh.
Try it again. All right, ready?
Okay. 10. I can't.
Let's try it one more time.
We didn't do this.
Let's try it again.
4.
Okay.
3.
Hey, don't cheat.
2.
Okay, so that would be visual fields. And you can do that with both eyes. It's usually not something we're going to do unless you're working in an area where you're doing some sort of community screenings, but you might see it be done on a patient and you need to know what's going on. So first was just general vision using some sort of optic chart, and then the second is visual fields. Third, we're going to do 3, 4, and 6 together. That's going to be oculomotor, trochlear, and abducens. So those govern eye movements, which includes the pupils dilating and constricting, and then also just pupillary movement in terms of moving your eyes around. So the first thing is diagnostic fields of gaze. So we need the patient to look that way, that way, that way, and that way. So an easy way to do this is with the big H. You want to go fairly slow, and you want to make sure your finger is about 1.5 feet to 2 feet away at the closest point here. Make sure their eyes go all the way to the corner on all sides. All right, so that is diagnostic positions of gaze. And then the next one is using a light to see if her eyes dilate or constrict when the light shines on them. And you want to shine the light in each eye twice. So the first time you shine the light in this eye, you're looking for this eye to constrict. That's called direct constriction. The second time when you do it, you're looking for that eye to constrict, and that's called consensual constriction. Then you can also ask the patient to look at you and shine the light in their eye to see where the light reflects off of their cornea, and that should be in the center of the pupils on both eyes. If it's not in the center, that's a sign that one eye is not tracking equally with the other eye. So now we've done cranial nerves 1, 2, 3, 4, and 6. And then we've got going back to number 5, which is trigeminal. So for the trigeminal, tri means 3 and gem means root. So this has three branches off of the root. So you've got a temporal, you've got a facial, and then a mandibular root. So you need to be assessing all of those. Close your eyes, please. Tell me what you feel.
I feel it.
Where do you feel it?
Oh, up here. Up there. 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 There.
All right. And did it feel the same on each side, or did it feel different? Because sometimes you might be able to feel it on both sides, but one side feels lighter or more muted or number, just different. So you want to know if it feels the same or different on each side. The trigeminal nerve is also responsible for masseter. So when you ask the patient to bite down and feel the strength of the masseter contraction. All right, so that's cranial nerve number 5. Next, we're going to go to cranial nerve number 7, which is facial. So smile, frown, puff out your cheeks. Don't let me press them in. Close your eyes very, very, very tightly, and don't let me press up. Okay, so that's facial nerve. Next is cranial nerve number 8, which is sometimes known as acoustic or alternatively vestibulocochlear. And so for this, we need to test the patient's hearing. So for gross hearing, we're going to occlude the tragus of one ear. We're going to cover our mouth so she can't read our lips with her peripheral vision and say a 3-syllable word. Hospital.
Hospital.
And now a different word. Elephant.
Elephant.
So you whisper the word and see if they can repeat it back. You can also do some tests with a tuning fork. So this is called Rin's test. What do you hear?
I hear equal. I hear noise.
Okay, so they should hear the noise above their head or equally in both ears. If there's a problem, they'll say, well, the most common problem is I don't hear anything. And that's because either you didn't get enough vibration, or you waited too long, or you're not pressing firmly enough. So you want to go somewhere from the middle of their head forward to about mid-forehead. So not behind midline of their head. And you got to make sure you're pressing fairly firmly. Otherwise, they're not going to feel, or not going to hear it. So what they shouldn't do, though, is hear it on one side louder than the other. That would be a positive Weber test. Sorry, I think I said Rin. Weber test. The Rin test, what we're going to do is we're going to place the tuning fork on the mastoid. Do you hear that?
Mm-hmm.
Tell me when you stop hearing it.
Mm-hmm.
Do you hear anything now? So they should be able to hear the tuning fork about twice as long through air than they did through the bone conduction on the mastoid. So if they can't, if when they stop hearing it with the bone conduction, they can't hear it at all on the air conduction, that would be a positive Rin test. And then we can also do balance, but we're going to skip balance for the portion of this. We'll do that later on when we do the rest of the neuro exam. But vestibular is one of the functions of the vestibulocochlear nerve, so really you would ideally do that sometime during your exam. We're just going to skip it for now because we're doing everything in the head. Next we have cranial nerve number 9, which is glossopharyngeal. For this you're going to need a light source, and you may need a tongue depressor depending on how well they open their mouth. So what you are going to do is ask the patient to open their mouth, stick out their tongue, and say ah.
Ah.
Now what you're looking for is to see the uvula raise and soft palate raise midline. If it raises to one side or the other side, that would be abnormal. And this is testing glossopharyngeal and then also vagus nerve. We'll get some B-roll on that in a minute.
Okay.
Okay. Next, we can ask the patient to stick their tongue out.
Hold on. Okay.
And we observe to see whether it's pointing out midline. If it's pointing to one side or the other, then that is most likely a cranial nerve number 9 or a cranial nerve number 12 problem. Cranial nerve number 12 is hypoglossal, which innervates the underside of the tongue and helps to control tongue movements. You can also assess that by asking the patient to say some words like light, tight, and dynamite.
Light, tight, dynamite.
Or la, pa, ka.
La, pa, ka.
I don't know what the ka does, but hey. So there you have cranial nerve number 12. And we skipped cranial nerve number 11, which is the spinal accessory nerve, which we actually did as part of the musculoskeletal exam last week. So we can ask the patient to shrug their shoulders, and we can ask them to push forward, pull back, and turn your head to the side, and turn your head to the side. And again, we want to make sure they're turning their head, not just pushing sideways. So that's all the cranial nerves. The next portion of the neuro exam is sensory assessment. And for sensory assessment, we want to do both spinothalamic tract and then also posterior columnar tract. for the spinothalamic tract, we have light or gross touch, we have pain sensation, and then we have temperature sensation. So to do temperature sensation, you would fill up a little test tube with some hot water and some with cold water, and you ask the patient which one they're feeling. We're going to skip that for the purposes of this demonstration. So for light touch, what I want you to do is close your eyes, put your hands in your lap, and what do you feel?
Right there.
Right. And what do you feel?
Right there. Right there. Right there.
Right. Now, generally speaking, for sensation, if you test the most distal extremity, you assume that the nerve is intact all the way up. If, for example, she couldn't feel right here, then we would assess higher up and higher up and higher up until she could feel sensation. But if it's intact at the bottom, it should be intact all the way up. You want to do both hands, and you want to do the right, a middle, and a medial. And the reason for that is you have 3 different nerves that innervate your hand. So you want to be measuring all 3 of those nerves. Next, we have pain sensation. Hold on, I'm not prepared.
Oh, you need to stick me.
Yes, I am. I'm going to draw blood. Oh, did we get that on tape? I'm sorry.
I'm ready.
Okay. For pain sensation, you need to use something that is actually slightly sharp, but you don't want to use something that's so sharp that you're definitely going to break their skin. So try not to use like a needle that you would use in a syringe. That's too sharp. It's pretty much impossible not to break their skin. Something like this works about perfect, and you can close it up when you're done to safely throw it away. All right, close your eyes. And this is sharp.
Okay.
And this is dull.
All right.
So tell me which one you felt.
Sharp. Dull. Sharp. Sharp. Sharp.
Sharp. Sharp.
Dull.
Okay. Okay. So you want to switch it up a little bit every now and then, and you can also use the same one on the same part. So you could do sharp and dull on the same part if you needed to. An important thing here is if you use something like the end of an applicator, this isn't really sharp enough to really test pain sensation. So you're not really getting sharp or dull if you're doing this side versus this side. Next, we have, so that's the spinothalamic tract. We've done gross touch, we skipped temperature, and we showed pain. You can also do that on the feet, but we're not going to do that for the purposes of this demonstration. Next, we have position sense or proprioception. So what we're going to do is we're going to isolate one finger, the distal joint to that finger, because remember, if the distal one works, then we assume it works all the way up. So don't press from the bottom or the top, because then that gives just another cue, a clue of, oh, I'm being touched on the bottom, it must be going upwards. So instead, grab it from the side. Close your eyes, please. And you're going to wiggle their joint. This is up. This is down. Which one is it?
Down. Up.
And again, this is down. This is up. Which one is it?
Down. Up.
Okay, and the other hand?
Up. Down. Down. Up.
Okay, so that is proprioception or position sense. Then the last one is vibration. So close your eyes. What do you feel? Okay, now notice that my hand is underneath her finger. So when I test that distal joint, I can actually feel the vibration through her finger. So if she can't feel it, I know something's wrong with her, not with me. What do you feel?
I feel it. I feel it.
All right. Other hand.
I feel it. Nothing. I feel it.
Okay. All right. So you've got vibration. So for the spinothalamic tract, we have light touch, we have pain perception, temperature, and then position sense and vibration sense. For the posterior columnar tract, we're going to be testing a number of other things. So there's 5 of them that we're going to learn, but you're going to demonstrate 2 of them on your head-to-toe checkoff, and you're going to get to choose which 2. So the first one is called graph esthesia. Graph means to draw, esthesia means feel. So I'm going to actually ask you to do it this way so we can kind of feel. I'm going to show them first. So we're going to draw a letter on her hand. That was a P. And then we'll ask her to close her eyes, and we'll ask her to say, what was that? Now, at the moment, we're cheating because we're facing her hand away from her. To do this for real, you want to face the hand toward them and close your eyes. So that was a P. What letter is that?
S.
And what letter is that?
T.
And then we'll do the other hand. This is a P. What letter is that?
M.
And what letter is that?
R.
Okay, one thing to be aware of is that R's and K's have a tendency to feel very similar, and K's and H's and A's are also fairly similar as well. So you have to be careful that you're not choosing letters that are too similar to each other. Okay, next what we're going to have the patient do is recognize an object by feel, and that's called Stereognosis. Stereo means impression, and then gnosis means know. So what can she know by the impression on her hand? So for this, I want you to close your eyes. And what is that?
A safety pin.
Other hand, please. And what's that?
Oh, a roll of tape.
Okay, so you want to make sure that you're using objects that are fairly easily recognizable by feel, and also something that the patient might be familiar with. So let's, for example, close your eyes, take out your hand, and what's this? She'll never guess because she doesn't even know what that is.
All right.
It's a nasal speculum. It's been used. No, it hasn't been used. Probably cut that part out. Next, we have something that's called point location. Point location is exactly what it sounds like. We're going to have the patient close their eyes. We're going to touch them and ask them to point to where they were touched. And you want to use some spots that are upper body and lower body and in different locations. So you're not always going to the exact same spot. Next, we have what's called 2-point discrimination. And for this, it works best if you have calipers, but you can also simulate it with something like this. So why don't you close your eyes, and I'm going to touch you with either 1 or 2.
Okay.
Can you feel that's 2?
Yeah.
And what you do is you say, is that 1 or 2?
Oh, the last one you did 1 and 2 there.
Well, is it 1 or 2? Which one is this?
Oh, that's 2. 2. 1. 2.
And every time you do it, you slightly narrow it until they can't tell the difference between 1 or 2. So it's their ability to discriminate between 1 and 2. That's 2-point discrimination. Sure, let's do it again.
I messed that up. I just want it to look better.
Is that 1 or 2?
2. 2. 1. 1.
All right, so that distance is where she was no longer able to tell the difference between 1 and 2. So you measure the distance where they can no longer tell the difference. And then the last one is called extinction. And with extinction, what you're going to do is you're going to touch them in 2 different spots on opposite sides of the body, 1 upper, 1 lower. And they should be able to tell you the 2 spots. So not pointing, but telling you what were the 2 spots. If they can only tell you 1 of those spots, then that's a positive extinction test. So one of the sensations, I guess, extincted the other. So close your eyes. And where were you touched?
On my arm over here, and my thigh over there.
All right. And do it again.
On my arm over here, my leg over there.
Very descriptive. All right, so that is the extinction test. So again, the 5 tests for the posterior columnar, these are sometimes known as fine localized touch. We have stereognosis, where they recognize an object by feel. Graph esthesia, where they recognize a letter being drawn in their hand. Point location, where they can point to where they were touched. Extinction, where you touch them in 2 different spots, upper and lower, opposite sides of the body, and see if they can feel both spots at the same time. And then the last one was 2-point discrimination, where you see the minimum distance or the maximum distance that they can detect 2 points versus 1 point being touched. All right, that was lovely. Next, we're going to do the motor exam. So for the motor exam, we have strength testing, we have reflexes, and we're going to do coordination. And then the last thing would be gait. So for strength, this is going to be very similar to what we did for musculoskeletal, except it's going to be shorter amount of time. And we've actually already done the first part when we did cranial nerve number 11, but just for the sake of completeness, we'll show you again. So press forward, pull back, turn your head to the side, turn your head to the side, shrug your shoulders, push your arms out, pull them in, hold your arms out straight, push down, push to the side, and in. Make a fist, push your hands out, pull in, squeeze my fingers, and let go. Okay. Pull up, push out, pull in, push out, pull in, and pull your toes up. All right, so we've done just a general brief strength exam. Then the next step is going to be to do reflexes. So when it comes to reflexes, you need a reflex hammer. So there's several different kinds that are named after the doctors that invented them. So there's this little kind, and this kind actually has a needle that you can use for sharp or dull, and it also has a little brush on the other side that you can use to do the light touch. This is your standard reflex hammer. These come in small and large, and they're pretty much, well, terrible. I don't recommend these. We also have this little job right here. It's got a little sharp point that you can use for sharp on the end of it there. It telescopes for maximal leverage, and you can flip it outwards or use it in this configuration. These are kind of fun. But this little FSU tomahawk is my absolute favorite, even though I'm not that big of a Seminole fan. But hey, these are actually the best. They have a really good weight to them, and once you whack a patient with this, you can't go back. So we've got several different reflexes that we need to assess. So the first one we're going to assess is the brachioradialis. We're going to strike the patient right about there. There's a little plexus of nerves right there. So to do this one, we're going to have the patient relax. You know, she's not there you go. So what you can do is tell the patient, like, drop your arm, make your arm as heavy as possible. So when they're relaxed like that, you cheated.
I know.
Close your eyes. All right. And so what we saw there is that her hand supinated and sometimes will also flex. So that's the reaction that you're looking for. You can also do it by having the patient relax their arm in their lap, but facing this way and striking there. This one can be a little bit difficult to find, and it's always a bit painful. Next, we have what's known as the biceps tendon. So for this, what we're going to do is ask the patient to relax their arm, and we're going to wrap our thumb around here and push it tight, and then you have to tap your own thumb. And what you'll feel is you'll feel that muscle contract. Hers is, now that one you can see. So that's what you're looking for there. The next one is the triceps tendon, and this one can be a little bit tricky. What we need to do is get their arm into this position and then have them relax. And again, this is an impingement position, so you don't want to jack this up too much or it will hurt your patient. So relax your arm. And you can use the flat this time, and you're going to tap just above the elbow joint. If it works, their arm will go like this, like she's trying to dance the robot. There you go. Next, we have what you're all familiar with, which is the patellar tendon. And for this, you want to feel the patella and then feel there's like an elastic band just underneath that patella. And that's the area you want to hit. If you hit it right, usually you'll get a response. Now, there are some patients that, for whatever reason, they just have very poor reflexes. It's hard to get them. So in order to do this, there's a couple things you can do. If they're flexible, you can ask them to cross their legs. So cross your knees like in this position. A lot of times you can actually get it pretty easily here. And her, ow, not working out. So go ahead and uncross your legs. The other thing you can also do is ask the patient to pull here. And what that does is give them something to do upper body to concentrate on, will allow you to elicit the reflexes down below. And then the last one that we have, it's not going to work with your shoes, I'm sorry. The last one is the Achilles tendon. So for this, what we're going to do is we're going to relax your foot.
Okay.
This is hard. You have to ask them to relax their foot.
All right.
You pull their foot up and then tap on the back. And when you get it, what will happen is their foot will plantar flex. But again, it's kind of difficult to get because relax. There you go. Relax your foot. There you go.
Yeah.
And you've got to be careful on this. If you go too low, you'll be hitting on the back of the calcaneus bone, and that hurts. So make sure you're not going too low. Same thing here. If you go too high, you're going to hit on the patella, and that will hurt. So those are your 5 reflexes. You need to be able to know what they are and have practiced all of them, but on your final checkoff, you're only going to do the patellar, at least required to do the patellar. The next step on our motor exam is we're going to do coordination, and this is test of cerebellar function. So there's a couple different coordination tests you can do. You just choose one for your checkoff. You don't need to do all of them. So the first one is called finger to nose. You're going to stand directly in front of the patient's face, nose to nose, and you're going to hold your finger out to the side. What I want you to do is touch my finger with your finger, but don't look at it.
Okay.
Okay. Now touch your nose and touch my finger. Touch your nose, touch my finger. Keep going. And now close your eyes. All right, so that's it. That's finger to nose. The keys to this, you have to be directly in front of the patient. You need to have your finger out to the side. They touch it while they look at you. And it's a lot of times you have a tendency to say, touch my nose. Try not to do that. So touch my finger, touch your nose. There you go. The next one is called rapid alternating movement. So put your hands in your lap and then flip your hands over and then back. Keep going. And now go faster, faster, and go as fast as you can go. So if patients, what can happen sometimes is when they're doing it slow, they can keep it together. But as you go faster, and you can actually try this on your friends the next time they imbibe some alcohol. And what you'll see is that a person who is drunk has a much harder time doing that sort of thing. If you ever notice that someone who's drunk can kind of sway and dance a bit, but once you get them to do a little bit more than that, they can't. Well, that's kind of what's happening in this case. The last one is the heel to shin. So what I want you to do is take your heel, put it on your knee, and then run it down your shin without looking. Okay. And that's it for the cerebellar function tests that we are going to be asking you to do. Again, you're going to choose one of those and do it on your final checkoff. So then the last thing we're going to do is balance tests and gait tests. Okay, so go ahead and stand up.
Yeah, we're going to have to re-angle this.
And we'll have to move back because we're going to want to see her walk too. Show me to walk this way.
Just left a little band there for you.
Oh yeah? What did you do?
You'll see it.
You tried to kick me, didn't you?
No, not at all.
Okay, so for balance tests, there's a couple you can do. One is a one-legged squat, which is quite difficult, especially when you have a patient who's older, weaker, or has neurological problems. So for that,
We're going to cut this, but I just want to say, can I do it?
so there's kind of a one-legged squat.
I can't do that side. Oh! Ow!
Anyway, so one-legged squat. The other thing you can do is called a Romberg test. So for the Romberg test, I want you to hold your arms out in front of you, and you can actually hold them for the patient. Close your eyes, and now I want you to stay still. And so what you do is you observe the patient, depending on the source, 10 to 30 seconds, and see if they can hold that position. If they can't, then that's called a positive Romberg test. The last thing we're going to do is we're going to ask the patient to walk, and we're going to assess their gait. So come over here, and I want you to walk forward. Then I want you to turn around and walk on your toes. This is called a toe walk. You would have never guessed. Turn around again and walk on your heels. This is called a heel walk. You would have never guessed. And then finally, I want you to turn around and I want you to, without looking, walk with one toe right in front of the other heel. And this is known as tandem walking. Now, you may have noticed that there's some overlap between some of these tests and, well, what we might call drunk tests, or drunk driver tests. And what the police officer is doing in a drunk driver test is actually asking you to do coordination tests, because when you're drunk, you have a harder time coordinating. And that is it for our neuro exam. So we started with the mental status exam, which we're going to do in a voice thread, not in a video. And then we did the cranial nerves, the sensory exam, the motor exam, and we ended the motor exam with balance and gait. All right, so that was our little intro.
That was good. You tied it all together.
So let's...
All right, party people.
All right, party people, let's learn how to do some cranial nerves, everybody.
All right.
I'm channeling my inner Adam Sandler.
Which movie, though?
Oh, that was Billy Madison.
Really?
Yeah. I'm just trying to learn.
Yeah.
She's talking about making out with me. I'm just here to learn, everybody.
That movie's so good. I drew a blue duck because I always wanted to know what one would look like.
I can't wait to go to high school. Don't ever say that.
I do that
Stay
to my dog.
here.
I do it to my dog all the time. I take her face and I go, "Don't die."
Stay as long as you can. Okay. Take 8, 100 million.